Welcome to the third part of this program on interceptive and ultra-conservative treatment of tooth wear. I would like now to share with you protocols for more severe cases of tooth wear using a direct and indirect treatment strategy. And I will concentrate on the third part on molding and hybrid clinical protocols. There are more clinical protocols depending on some peculiar aspects of tooth wear, but I think the one that I have shared with you in the part 1 and the one that I will share now in the part 3, part 1, part 2 and part 3 are dedicated mainly to interceptive treatment of tooth wear. There is still the restorative strategy where we go with more classical type of restorations in the form of overlays, possibly crowns, corresponds more to classical prosthodontics. So I think what is really new in the treatment of tooth wear is this interceptive strategy, in my opinion. So I will start first with a case of full molding, and then we'll go with a hybrid case using ceramics and composite. This is the selective treatment approach. And I will finish with a case of selective treatment approach with 20-year follow-up. So the question, when you need to increase the video, when you need to change the anterior guidance, when you need to improve aesthetics, is how you transfer what you plant on models with analog wax up or digital wax up to the mouth. How accurate can the transfer be from the lab to the mouth? And this is really the most difficult part for colleagues who might not be really experienced with direct bonding. If you love to do your class 1 and 2 restorations with a direct approach, you might be relatively comfortable with the direct approach, the freehand approach. If you are not, then there are alternative options, which is the partial and the full molding. By experience, the full molding has many advantages, especially in terms of time. You'll be faster with the full molding. But the partial molding might be an option, but I don't have really the time to present more cases. But the concept of the partial molding is that you build up, with help of the index, your cusp line. So you will build up all the cusp from premolars to second molar, possibly the canine, facial and lingual, or facial and palatal, and you are left only with the small area in the middle. But of course, as you understand, you have more steps involved. While the full molding, you have a full index that comes over the teeth. So it's a very efficient protocol, but you must be very specific, very detailed in the application of the protocol. Otherwise, the time you save during molding, you will lose for removing excesses. But I will explain this in details a little bit later. So as I said, in the second part, a very important step or consideration about using composite for tooth wear treatment is to have some reference point. You want to get reference points in the proximal with your contact points, marginal ridges, and also you want to see the central groove, or what remains for the central groove, as a visual reference to create a correct occlusion. If you have no reference where the central grooves, how the cusp were organized, it's more difficult, of course. So when you get very limited tooth wear, it's very easy. When you get a little bit more advanced tooth wear, you lose progressively your reference point. You have more material, more tooth structure to replace, more material to add. And of course, it's becoming technically a little more difficult. And that's why, in that situation, I might prefer to use the molding technique. So let's start with now a step-by-step case. It will be a video also to show the dynamics of the treatment, because with step-by-step just images, still images, sometimes we do not really catch all the details. So you see here again a hybrid case. You have a combination in the cervical areas of probably abfraction, erosion, abrasion. You have signs of relatively severe attrition and also erosion of the facial. So this patient is a classical case of hybrid pathology. I think on this image it summarizes really everything that we need to understand about the risk factor and the pathology. You see also here on the lower front teeth, but that was after I restored already the canines. So you see that the canines are not worn, but in fact they were already restored on that image. If you look at the occlusal surfaces, it's quite amazing to see that despite the severity of attrition and erosion in certain areas, you have nearly nothing on the back teeth. So you might think, yes, in fact, it's not really an attrition case, probably a patient eating a lot of fruits. Some patients, they love lemon, so they create a lot of erosion on the front teeth when they bite into the lemon or acid fruits, but there isn't much parafunctions. Now look at the night guard. There is attrition. There is severe attrition. The patient has been on the night guard therapy or preventive therapy. That was here more for financial reasons for a couple of years, but at least we could witness the fact that the patient is a compliant patient. She's wearing the night guard. But again, unbalanced diet goes very often with a stressed personality and parafunctions. So, diagnostic as a summary: erosion, attrition. But erosion and attrition didn't develop in the same magnitude everywhere in the mouth. And this case is not unique. What is unique are patients with regular tooth wear, uniform erosion over the whole mouth, or uniform attrition over the whole mouth. Those are more exceptions than the rule. This is typically a hybrid case with differential tooth wear, attrition and erosion on different parts of the mouth. And we suspect, because she confirmed that during the day, she's having some parafunction. So she's also an awake bruxer. She's probably bruxing a little more than clenching because she has worn down more her front teeth. On the lower arch, we don't have a lot of tooth wear. You will see a little bit better on the detailed views. So what is the treatment plan? The treatment plan based on the wax up is to restore, to increase the VDO, because we need space to restore the lower front teeth and the upper front teeth. So we'll increase the VDO by adding material on the posterior lower teeth and also, of course, on the lower front teeth. And we'll restore the upper 6 front teeth, palatal, facial, and incisally. So you see that this type of treatment concept or scheme is quite logical, of course, but you like to get the wax up in order to get everything under control. And this is the lateral view of the foreseen rehabilitation. Here, for financial reasons, we had to wait a few years before we could start the treatment, and for obvious financial reasons, it was decided to do everything with composite. We did a mock-up only to evaluate the tooth display because the upper front teeth were relatively short. We wanted to avoid too much overbite. We wanted to avoid also surgical crown lengthening. That was also for financial reasons. We wanted to limit the impact of the treatment, and not only from a biomechanical perspective, but also from a financial perspective. So this very primitive mock-up is just helping to define whether functionally and aesthetically our anterior situation is correct. Now you see details of the posterior situation before we'll restore both sides with the molding technique. And I mentioned attrition, I mentioned clenching, mentioned bruxism and clenching. They are both attrition pathologies. Clenching, as you know, is with limited movement. So you more have high forces, closing forces, while with bruxism, the patient is having broader excursive movements. But here you see that we have some clenching. We have erosion, some signs of erosion with hollowed lesions, but also some signs of bruxism and probably clenching. When you get fractures of intact marginal ridges, because there is no decay on those teeth interproximal, that's usually more correlated to clenching rather than bruxism, unless you have lost completely anterior guidance. But even here, you see that we have some severe wear on some contacts, but the cusp were not taken away completely by lateral protrusive movements. Now, this is the way we do it. We have a hard tray that we need to cut, especially in the proximal, so that we get access to remove the excesses of composite. And this is relined with a transparent silicone, but you will see the details on the video. And we use a combination of an isolation material to block the proximal contacts and also Teflon tape to block eventually the interproximal areas. We don't want the composite to be pushed below the contact area. In fact, we don't want composite inside the contact and below the contact. That's the key, one of the key points to facilitate the removal of composite excesses. This is after we took out the mold and before we start with the cleaning. In fact, if you prevent the etching to go everywhere, some of those excesses are not bonded to the tooth, so they are very easy to take away with a scaler or with a number 12 blade. So we'll do a little bit with the blade and scaler to start with, but you will see the details on the video. Then we go with discs and burrs, and then the case is completed. So now this is after this first finishing part. On the right-hand side, after the characterization, we love to paint the surface. It's irrational. Don't do too much in women patients. Some might not like it, but a little bit of color on the surface makes the restoration look really very natural, very nice. And this is basically just before taking the rubber dam out. We calculate normally about 5 minutes of finishing per tooth. So the molding goes very, very quick, and the finishing is about 20 minutes until you can remove the rubber dam and check your occlusion. This is the situation on the other side. We didn't have any fracture of marginal ridges, so on this side you only see the wear at the level of cusps, maybe some indentations, combination of erosion and clenching. And this is after the molding. Well, sometimes with the full molding, maybe your occlusal grooves are a little bit less refined compared to what you can do with a direct or indirect approach. But on number 7, it is not so important if you have very, very deep grooves or not. Anyway, we don't want to fragilize this thin build-up. So having very thin and sharp grooves is maybe not, occlusal grooves is maybe not mandatory. So this is the full right lower posterior sextant, and we are ready now to take the rubber